Okay, ji, so let's talk about the factors that increase risk of limb loss in patients with critical limb ischemia. So there are a number of factors that can reduce blood flow to the microvascular channels. One of the most common causes is diabetes. Then there comes the severe renal failure, severely decreased cardiac output. For example, in the patient with the heart attack, in the heart failure or in the stroke patient. Raynaud's phenomena, prolonged coal exposure, smoking and tobacco use for the persons who have been smokers for since long, and the factors that increase demand for blood flow to the microvascular bed it involves infection, but the deep infections, for example, cellulitis, osteomyelitis, and skin breakdown or the traumatic injury. So they are the symptom. There are some factors that can lead to increased blood supply. Demand of increased blood supply. 50 to 90% of patients with definite intermittent claudication do not report their symptoms to clinicians. They are just sometimes some patients are just relaxed that their pain can be due to this reason or that reason, or they just ignore their symptoms. That is why when the symptoms cross that threshold or the symptoms become so much severe that now there is no much they cannot they cannot tolerate those symptoms. Only then they report to clinicians. Most patients appear to accept a decrease in walking distance as a part of aging. Yeah, this is the most common uh, basic myth, I must say. Whenever there is some kind of pain or there is some kind of decrease in the efficiency of a person, they always blame the age, that now this can be due to my increased age or that can be due to my increased age. So that, but this that is not uh, logical. I say this is not a good answer for everything to blame your age. So you must can you can have a visit to the clinician just in order to rule out that either there is some pathology present or not, or they are just minor symptoms. The risk factors for peripheral arterial disease are the same as those for the chronic, as those for the arterial deficiency or cerebrovascular disease, and they include the following: diabetes, hypertension, hyperlipidemia, family history, sedentary lifestyle, and tobacco use. They all are the risk factors that lead to development of the atherosclerosis. And if there is atherosclerosis, obviously the chances of peripheral arterial disease or arterial ulcers, they will be very much increased. And smoking is greatest of all the cardiovascular risk factors mechanism, that how the smoking is so much dangerous, or how this is making a person so much prone to peripheral arterial diseases is still unknown. Degree of damage is directly related to amount of tobacco use. So, a patient with the peripheral arterial diseases has been reported to you. Now, you have to examine the patient, and what will be the plan for the physical examination? You have to go for complete lower extremity evaluation, and you will check the pulse of the patient as well. Pulses should be examined from the abdominal aorta to the foot. The absence of a pulse signifies arterial obstruction. All right. The next physical examination you have to check all the five symptoms that I have told you already. You can check the pain, you can go for the tenderness checking, you can go for the pulse checking, you can go for the paresthesia, you can go for the paralysis, the paresis checking, or you can go for the pallor or the color changes. Right? The first tool to establish the PAD diagnosis, this is always a standard physical examination in which you can go for the pulse checking. Pulse intensity should be assessed and should be recorded numerically as follows. Either the pulse is absent, or this is diminished, or this is normal, or the pulse is pounding. Okay, so 0, 1, 2, 3. This is how you can grade your pulse intensity. 0 go for absent pulse, 1 for diminished pulse, 2 for normal pulse, and 3 for bounding pulse. And how to do evaluation of a patient with critical limb ischemia? Patient at risk of critical limb ischemia, they should undergo regular inspection of the feet to detect objective signs, and the feet should be examined directly with the shoes, and socks must be removed, and the examination must be carried at regular intervals after successful treatment of the critical limb ischemia. You can go for auscultation of roots in the abdominal pelvic region as well. You can check the atrophy of calf muscle, you can go for the checking of the strength of the calf muscles. You can, during the examination and inspection, you can check the either there are loss of extremity here or not, or they are present, and what is the texture, what is the appearance of the skin of the calf area and the foot area, either that is shiny or not, what is the texture of the nail, either they are too thick or not, and they are the clues that can lead to the signs of PAD. Okay. When palpable pulses are not present, further assessment with handheld Doppler device. In investigation section, I will tell you that how to use Doppler device for examination of for assessment of PAD. An audible Doppler signal assures a clinician that some blood flow is perfusing the extremity. And if no Doppler signals can be heard, a vascular surgeon should be consulted immediately. Vascular surgeons are specialized for treating these vascular abnormalities like the PAD and the other ones. So there comes investigation section. I will tell you in the coming slide. There's some symptoms according to the Fontaine classification. Stage one is labeled as symptomatic. Two is mild if called claudication. 2B is moderate to severe claudication. 3 is ischemic chest pain. And fourth one is ulceration and gangrene. While in the Rutherford classification, they classify the symptoms from the 0 to 6, while in the Fontaine, they classify the symptoms as the 5 stages. Okay. While in the Rutherford, we have 6 categories. Basically, we have 7, but the numbering is done from the 0 to 6 minutes. So in the investigation portion, so far what we have discussed, first of all, we had an idea of the PAD, what were the risk factors of the PAD, and afterwards how to do the physical examination of the feet and of the legs. And now is the investigation section, that is the ankle brachial index. This is the most commonly used tool, which is 95% sensitive and 99% specific for the assessment of PAD, and it basically establishes the diagnosis of PAD. It identifies a population at high risk of severe ischemic events, and the population at risk can be clinically and epidemiologically defined as exertional like symptoms, non-healing wounds, age must be more than 50, must be more than 70, and a history of smoking or diabetes. So they are the symptoms, they are the basic criteria, and these persons having these characteristics, they must undergo ankle brachial index assessment. So what is ankle brachial assessment index assessment? Ankle brachial index is showing that we will take the ankle's blood pressure, the pressure from the ankle, and then we will divide that systolic pressure, the pressure from the blood pressure which is taken from your arm, the brachial artery, and the lower extremity blood pressure will be divided by the brachial artery blood pressure. Okay, let me show you the diagram. Afterwards, I will show you the video of the procedure. But I have still added or attached that video of ABI assessment in the Google Classroom. So in the first one, what we will do, first of all, we will put the cuff of the sphygmomanometer cuff around the arm, and Doppler ultrasound will be used around that area where that is being, the cuff has been tied on the arm. And in the second portion, pressure will be recorded in the brachial artery of the arm through the gauge of the stethoscope, through the gauge of the blood pressure apparatus. Okay, and afterwards this cuff will be removed from the arm, and then it will be tied onto the onto area just above your lateral malleoli, and Doppler will be placed again here after the application of the ultrasonic gel. And now the sound of arterial blood flow will be located, that will locate in that will the blood flow will be located by the Doppler handheld Doppler device. And in the last phase, what we will do, pressure will be recorded in arteries of the ankle after each arterial flow is located. Okay, so you have to put the cuff first of all on your arm, and afterwards you have to measure the You have to measure the pressure of the brachial artery, and then you have to tie that cuff on your ankle, or just on the last or the lower end of your lower leg, just above the lateral malleoli, and then you will place your Doppler over there, and then you will record the pressure as well. Okay, so an accurate pressure reading is obtained as follows. Place the pneumatic cuff around the ankle. Position the Doppler probe over the dorsalis pedis or the posterior tibial artery. Inflate the cuff to a reading above the systolic and pressure, and deflate the systolic tone and the ankle vessel in the pressure is recorded. I put a very brief and comprehensive video that has been attached in your Google Classroom. So when you will have a look at that video, the procedure will be memorized. A healthy person, the person of the hill up a person who is healthy can have a pressure of around 10 to 20 millimeter mercury, and in a patient with the claudication the measured pressure at the ankle will be, obviously it will be diminished depending upon the severity of PAD. And a useful tool in assessing a patient with a claudication is always the ABI, and the ratio of systolic blood pressure at the ankle to systolic blood pressure in the arm. This is the ABI, and the normal ABI is always between the zero point 0.9 to 1.1. But if the ABI comes to be less than zero point 0.9, that means the patient is suffering from the PAD. So let's this have a look at the interpretation of the ABI. If the ABI ranges between 1 to 1.29, that means if the person is having normal ABI. 0.91 to 0.99 means the person is at borderline of PAD, development of to PAD. If the person is having 0.41 to 0.90, it means that he or she is having mild to moderate disease. If the person is having ABI less than 0.40, that means the disease is severe. And if that means it is more than 1.30, that means there is non-compressible condition, so you cannot go for that, and the person must contact a vascular surgeon as early as possible. You can also go for the treadmill test for the ABI testing, but when it is indicated when the ABI is normal or borderline, but the symptoms are consistent with claudication, and an ABI fall post exercise supports a PAD diagnosis and assesses functional capacity of the person. But have to you must remember the ABI and the significance of ABI and the procedure of ABI very well in your PAD, but you can have an idea about the treatment test as well. ABI, it may be a less accurate assessment tool in the patients with diabetes, and peripheral vessels in patients with diabetes may have extensive medial layer calcinosis, which renders the vessel resistant to compression by the pneumatic cuff. So there can be some false positive or false negative results as well. Okay. Toe brachial index measurement. What is this in the toe brachial index measurement? What we do, we basically divide the toe pressure by higher of the two brachial pressures, and TBI value remains accurate when ABI values are not possible. So this is used only in case when you cannot go for or when you cannot rely on the ABI, but you have to remember that ABI test very well. Differential diagnosis are also there. Just have a look at the differential diagnosis, but there is no need to write these differential diagnoses in the question if you attempt that question in the PAD. Chronic venous insufficiency, compartment syndrome, degenerative disc disease, osteoarthritis, stenosis, thromboangiitis, obliterans, varicose. When they are the these through which out of which we have to diagnose if the patient is if the patient is having PAD or not. Okay, so these are the differential diagnosis if the pain is of neuropathic ulcer and neuroischemic ulcer. About neuropathic ulcer, we will study about it in the upcoming lectures. While in the neuroischemic ulcer, just remember that the patient is having pain, pulses will be absent, margins will be irregular, commonly located on the toes, callus absent or infrequent. There can be difference in the sensory feelings. Blood flow will be decreased, veins will be collapsed, feet are usually cold, there are usually no bony deformities. So they are the conditions. Okay. Then you can also go for renal function test. RFTs can be done also. Lipid profiles can also be checked. You can also go for angiography. You can also go for the computed tomography angiography. You can also take assistance from the magnetic resonance angiography and duplex ultrasonography. can also be used, but according to your book, you must go for the ABI test and the angiography and CTA. Okay, so you have to remember these points. So, so now let's come towards the management of the PAD. In the PAD, they say that there is a specific guideline on which we have to work. We recognize the at-risk groups leads to recognition of the five main PAD clinical syndromes. So how they classify the things. They classify the things that if there is non-leg pain, there is atypical leg pain, there is classic claudication, there is chronic critical limb ischemia, or there is acute limb ischemia. So you have to go for ABI measurement in order to assess and differentiate between these symptoms. Okay, or you can also take support from the standard angiography. Angiography is a criteria standard arterial imaging used for diagnosis of PAD, and it is usually reserved for when an intervention is planned. You have to check the exact location of the blockage. So you have to the patient has to undergo the procedure of angiography. This is a picture taken from the angiography, and this is the whole arterial distribution. MRI is useful for imaging large and small vessels. It can also help to plan the type of intervention. CTA is another modality used to image arterial diseases. Duplex ultrasound can also be used, but you can use when you have to go for non-invasive technique or you require no constrained media, but it is highly technician dependent or technician dependent. Okay, and what will be the advantage you can take from arterial duplex ultrasound? A duplex ultrasound of the extremities is useful to diagnose anatomic location and degree of stenosis of peripheral arterial disease. So just remember this point, that this is important in the diagnosis of anatomical location and degree of stenosis of peripheral arterial disease. All right. It also provides surveillance to the specific arterial location if you want. But again, the data that support use of duplex ultrasound, it assesses long-term potency of PTA, but that is not known. And what is the role of MRA? MRA is basically useful to diagnose anatomical location and degree of stenosis of PAD. And MRA of extremities should be performed with some kind of enhancement so that you can have a very good idea. MRI of extremities is useful in selecting patients with lower extremity PAD as candidates for endovascular interventions only. Okay. Okay. So just have an idea about the names of the test and what is the significance of the test if the test is advised to the patient. Treatment of claudication is medical except in severe cases, and in severe cases, you can go for the surgery. The surgery can involve the bypass grafting, it can involve the removal or the breakdown of the atherectomy, or you can go for the angioplasty. They are the basic surgical options available. But the goal of the treatment is to impede the progression of the disease, so you can go for the pharmacological option, or you can also have non-pharmacological option. Smoking cessation, if the patient is smoking, then he has to stop the smoking if he wants to recover from these symptoms. So, what is the recommendation for the pharmacological therapy? In the pharmacological therapy, obviously, aspirin comes first, and as the antiplatelet therapy, this aspirin is the best choice. And standard dosage range from 81 to 325 milligram per day, but no consensus has been reached on the most effective dose of the aspirin. And pentoxifylline shows also some prominent changes. And RCTs have been done on the pentoxifylline that shows that if pentoxifylline will be used, then there is chances of improvement in the walking distance of the patient, but this has been proved through some RCTs. Clopidogrel can also be used. Silacitrazole can also be used, which increases the walking distance. It can also improve the lipid profile of the patient, and over the statins can also be used because they will be used as what must be the best possible combination of these drugs. That depends upon the choice of the vascular surgeon or the neurosurgeon. So these are the available options. Antiplatelet therapy is indicated to reduce the risk of myocardial infarction, stroke, vascular death in individuals with atherosclerotic lower extremity PAD. And aspirin is also recommended as safe and effective antiplatelet therapy. Clopidogrel 75 milligram per day is also recommended. If you want to go for clopidogrel, then you cannot go for the aspirin because both are doing having the same mechanism of action, that both of them are antiplatelet drugs. And you can have both options simultaneously, aspirin or clopidogrel. But what must be advised? It depends upon the choice of your clinician. Silosidazole is also indicated as an effective therapy to improve symptoms and increase walking distance in patients with lower extremity PAD and intermittent claudication. And what are the additional regimes? You have to control diabetes, and if you want to control that, the other risk factors out of those, the most common will be the smoking cessation, most common will be the obesity control, weight control, and the diabetes, a good control of diabetes. In the surgical intervention, the possible options are the open bypass surgery or endovascular therapy, in which you can go for angioplasty, in which you have to insert the stents or the balloons, or atherectomy you can go for. But in the surgical, when the patient will be becoming the candidate for surgical treatment, that there are two options. When the patient is candidate for surgical treatment, patient is having more severe symptoms, or the conservative or the non-surgical management has been failed. And surgery is not indicated in patients with severe decrements in the limb perfusion in the absence of clinical symptoms of critical limb ischemia, and patients who have significant necrosis of the weight-bearing portion of the foot, uncorrectable flexion contracture, paresis of the extremity, refractory ischemic limb pain. They must be evaluated for primary evaluation as well. Okay, so they are the guidelines. And what is the role of physical activity? Obviously, regular walking program results in substantial improvement. A daily walking program of 45 to 60 minutes is recommended at least. Out of 7 days, at least you must go for a walk for at least 5 days a week in around 35 to 45 minutes. The patient walks until claudication pain occurs, rests until the pain subsides, and then repeats the cycle. Exact mechanism is unknown. Conditioned muscles work more effectively. For example, they can extract more blood and increase collateral vessel formation can also be there with the help of the physical exercises. A program of supervised exercise training is recommended as an initial treatment modality for patients with intermittent claudication, and the supervised exercise training should be performed for a minimum of 30 to 45 minutes in sessions performed at least 3 times per week for a minimum of 12 weeks. And what is a long-term monitoring goal? Every 4 to 6 months to assess the effects of therapy. Hypertension, diabetes must be controlled. A repeat pulse examination should be performed, and ABI should be measured regularly. If the patient's symptoms are worsening, then intervention and referral to the vascular surgeon. They are the best options. What can be the complications from PAD? Obviously, the gangrene can be there, which can lead to the amputation. So, limb-threatening ischemia leading to amputation is the first complication, and the second complication is that the claudication can become so much worse. As according to a study, in that study, only after 8 years the patient were at the stage of amputation. Prognosis is predicted mortality for patients with claudication is approximately 30% at 5 years, 50% in 10 years, and 70% at 15 years. Okay, so these were the facts relevant to the PAD. So you have to remember the definition of PAD. What is claudication? How you will differentiate claudication? That is a basic symptom of PAD. And what are the five signs? There are the five P's: pallor, paresthesia, paralysis, and the pain. And paralysis, pain, paresthesia, pallor, and pulselessness. Okay. And then you have to go for investigations. Investigation involve the examination, the skin assessment, the skin inspection, then ABI assessment. In the investigation portion, we have ABI investigation, ABI assessment, ultrasound usage. And in the treatment section, there are two options available. Either you can go for the pharmacological option, you can go for the surgical option. In the pharmacological option, we can go for the antiplatelet therapy drugs, while in the surgical option, we can go for the open bypass surgery, or you can go for the angioplasty, stunting, or you can go for the atherectomy. So this is about the PAD. If you want to ask any question, then you can ask me, and inshallah, next time we will be discussing the next type also.